Welcome to another one of our, the doctor is in through my Instagram live stream. And I'm starting actually a YouTube channel called Trail Doc Blog. And there will be a link on this, and I'll send it out to social media and everything. Really appreciate all the feedback and questions and interactions so far, and hopefully this has been helping our community deal with this pandemic. Today I'm really lucky to have two great physicians to give their experience and input on how to deal with this pandemic, and I will be bringing them on shortly. However, I just want to do a quick kind of just disclaimer and general understanding. This video doesn't construe actual medical advice. These are our opinions and our ideas and thoughts, but we're not certainly telling you giving anyone who's watching this any direct medical care or medical advice specifically. You should definitely, if there's a question, try to reach your doctor or provider and make those decisions with that person. And also, we don't develop any sort of doctor-patient relationship in watching this videos or participating in this live stream. So get the legal stuff out of the way. All right, I'm gonna unmute Andy and Mark. Okay, so I'd like to introduce two good friends of mine, two outstanding runners and outstanding physicians who have very unique perspectives on this pandemic. First off, I'd like to introduce our medical director for the Western States 100, family practice doctor, and owner of his own practice in Reno, Dr. Andy Pasternak. So Andy, why don't you introduce yourself?
Hi, so yeah, I'm Andy Pasternak. I'm a family practice doc with Silver Sage Family Medicine in Reno, Nevada. I've been here, going on 22 years. And along with my roles in the ultra running community with Western States and TRT, I'm also been heavily involved with our state and county medical societies here in Nevada, trying to deal with the coronavirus epidemic. So it's interesting seeing this from a wide variety of angles, and within my private practice, and then more at the governmental side of things. So happy to be here, John. Thanks for having me.
Hey, thanks, Andy. And emergency room physician living in the Bay Area, Dr. Mark Tanaka, also a very well accomplished ultra runner and extremely smart person. So Mark, why don't you introduce yourself?
Hi, yeah, thanks, John and Andy. I've been in the Bay Area since 2003. I've been working with Kaiser Permanente in the East Bay, Hayward, now San Leandro, and Fremont in the emergency departments there.
Okay.
And I like to run, usually.
Definitely like to run. I think a lot of the trail runners and runners around the Bay Area, or even probably all over the world in many ways, probably know Mark Tanaka's name. Or may have seen him on the trails. Mark, I want to start with you, because you're in the thick of it, and the front lines in one of the hardest hit areas in California. And even though I do feel our mitigation strategy for the state is working, I wanted to know, what's your perspective on this? How do you think things have been going, and your general view of this pandemic so far?
So where do I begin? I'm really grateful that our state's response, headed by the governor and all of the really smart people working with him, working very hard, has pushed back the surge. We're still anticipating this, but it's later than we thought at the onset, and it's given our physical hospice area more time. I think the hardest area in the Bay Area that's been hit is the South Bay. I'm in the East Bay, and we've seen cases, but and responded to what's coming in, but we haven't been overwhelmed as of yet. So for this, I think I and my colleagues are, and all the staff that work at our hospitals and our emergency departments are cautiously relieved by this.
Have you done any preparation though? We're like here at UC Davis, we've noticed a gradual, not exponential, gradual increase in cases. Have you done anything special in your emergency room?
Yeah, so from early, we had preparations. From the get-go, there was, a PPE training that, all the doctors went through, and there's been lots of communication from our leadership, and also a lot of communication from the ground. So I know that a lot of what I learn about this is, for instance, through WhatsApp that my group uses, and we all have, my group's more than 70 physicians, I think maybe even 80, and we all come from different residencies and in different stages of our career. So, a lot of the recent hires, they're in touch with their attendings. Many of them are from New York and places east. So I've gotten kind of secondhand, once removed, accounts of what's been going on, which you can probably access in the, if you look along, in the online enough. But yeah, so, and then there's daily, my chief in the administration, there's almost daily communications about updates as our policies and our procedures have been constantly evolving. So it's a very dynamic process, and I'm pleased to be part of an organization that's been able to harness our resources and our talent so well.
Good.
Again, we haven't been tested the way really hard-hit areas such as New York City, among others, have been, not even a fraction of that.
But I think we've built up capacity. I think we can deal with the service at this point. Andy, what's going on in Reno?
So we're a little like California. I mean, I remember a lot of the projections were really saying that we were supposed to start peaking this weekend going into next week. And I remember when the CDC came out with their, 8-week guideline, they basically came out with an 8-week no big groups policy. And I think we're in that was sort of the start of my ultra running. I was like, okay, 8 weeks, so I can get my head around 8 weeks. And I think we're at about week 4 of that, because we really thought the surge is going to be coming about now. Fortunately, like California, I mean, we're seeing cases. We've had, I think, under 60 deaths in the state. And recently, we just had a nurse pass away the other day from COVID. But we're not seeing that big, overwhelming surge like they're seeing in New York or they saw in Italy. Yeah,
it seems like it's a little more gradual. But I've definitely seen, there's been an uptick, in a significant increase in the number of positives. Again, I think the challenge is like we're not testing enough, and the testing equipment that we have is, it's a limited amount of material, so we really have to limit it for very sick people in the hospital, or those who are very high risk and and are symptomatic, to save the not just the actual ability to do the test. I know UC Davis, we drastically increased our capacity to do testing, but it's, materials, all of that we have to be mindful of. We don't have enough material to do widespread, more liberal testing. And that's a challenge for Andy and I setting, and certainly for Mark, if you're in the emergency room, you're seeing, subclinical people where you're infected, or just to worry about people who are wanting to get tested with caution. We have a number of questions. I want to kind of get to them. We've had questions submitted from Instagram, from Facebook, from WhatsApp. I had a number of questions from a running group in New Zealand as well. And I've kind of consolidated them to about 7 questions that we're going to try to get through. I think what we'll do is start with some of the questions more specific to general coronavirus care, and then there's actually some running specific questions that are kind of interesting that we'll get to at the end. You know, one of the things that's come up recently is masks, and so CDC has recently given one of their very nebulous things. It's the Fed saying that we have to do this, or they just this advice. Sounds like more like advice. However, like Los Angeles is more firmly set specific rules for wearing cloth masks in public, and these are for every. You're in a crowded area like a store, post office. You're work if you're still going to work. If you're lucky people whose job is considered necessary, that you're supposed to wear some sort of cloth cover. So one of the questions was like, well, if I go to a supermarket, could I just wear a buff over my face, or any of these, hundreds of different cloth masks you can get on Etsy? Are those good enough? And I was curious to see what your thoughts are on that.
I can go first, Andy.
Yeah, take it.
Okay, well, is it helpful? I think so. It probably is. Though that's the short answer. There's a longer answer, and if anyone who follows this, the data changes and the information and the recommendations have changed. Even within my hospital, much less out in the community, our policies about masks have changed. In the beginning, without going into too much detail, I mean, there was a big concern about conserving masks and other things. And now we can wear, I know this might seem surprising, but we can wear masks now during a shift, even if we're not seeing a patient at the time. If you follow anything about certain hospitals around the country, that hasn't always been the case. And so one other long answer thing, I mean, I think the distinction that is made in terms of the transmissibility of respiratory illnesses is whether it's airborne or whether it's droplet. So the general cutoff for the size of the particle that's transmitted is 5 microns. So the idea, if it's smaller than 5 microns, which is 5/1000ths of a millimeter, I believe, in diameter, that it can aerosolize and be airborne and stay around longer, as opposed to droplets, which will generally fall within, most of them fall within 6 feet. I think that's where the 6-foot figure comes from. Obviously, with a new pathogen, it's really hard to know all this stuff. We don't have enough time and enough data on this, so it's been revised. I think the bottom line is, though, that a mask, even if someone isn't sneezing or coughing, even just in the course of talking or breathing hard, especially like running, stuff goes into the air. Andy, and there's a lot of, this is just the short answer. I've read up a lot on it. It's not like I'm an expert in any of this, but I've read a lot, so.
Yeah. And I would agree with you, Mark. The data on this just, 2-3 days ago, I mean, I'm still very pro-mask. I'm still in your department. I think in Nevada, there's going to be some new recommendations coming out that when patients come into any setting, all patients need to wear a mask and all providers need to be wearing, any healthcare providers need to be wearing a mask. We've been doing that in my office, essentially, for the patients that we are seeing in person. They're supposed to be wearing masks. We're wearing masks. It is interesting. There was just an article that came out, I think, in Annals of Internal Medicine yesterday or the day before, where they did, they had people cough into a petri dish wearing a mask and they could still find viral particles. I think the one caveat that I tell people with masks are, I think masks can be helpful, but masks can also get contaminated. And my wife's an anesthesiologist. One of the things that they're really having trained the anesthesiologists on, you put on the mask, you wash your hands, when you take off your mask, it's really critical that you wash your hands again. So I think if people are going to go out and wear a mask, I'm encouraging people to wear a mask, but you know, the mask, if there is virus in that mask, and you put, all of a sudden you take the mask off, you touch the mask, and then you touch your face again, you've just eliminated the reason for the mask. So I think masks are a good idea, but I think you need to be, typically what I'm doing in my office is I wash my hands, I put my mask on, wash them again, and then I go through that same routine when I'm taking them off.
Yeah, I think what, you know, Mark and both of you are pointing out is that, you know, the use of masks is complex. I think, you know, the CDC essentially there's a differentiation between you know, putting on a mask as a healthcare provider where you're seeing sick patients over and over again, and you're also exposing many sick patients over and over again, or you may be doing a procedure that you don't want to contaminate. And so, so that's, you know, there is a, you know, a sense of protecting both yourself and protecting patients. My understanding, looking at the literature, a lot of the kind of more broad use of type of cloth mask. So that's where I think like a buff is probably fine if you look at like some of the stuff that other people are using for masks, because we don't want people using surgical masks because those are not, we don't have a lot of those, and we want to save those for healthcare providers where those can be protecting sick patients, but also protecting providers from getting sick. The cloth masks, though, are primarily aimed at asymptomatic spread. And I think that's where the CDC really made this call, is they found, you know, looking at other countries that seem to be flattening the curve, like Korea, for example, that this widespread use of cloth masks by the general public seems to help. And so, but Andy's point is really well taken. Like if you go out and you have a mask on and people are coughing and stuff like that, if you're touching that mask, your hands aren't clean, you got to wash your hands if you're handling dirty material. And that's a really, really important point. But I think, you know, I think all of us are in agreement, especially now that, you know, we're starting to see this surge. This is the time where you're much more likely to run into someone who's asymptomatic, or you may be asymptomatic. And so by having a mask on, it reduces hopefully it'll reduce some of the transmission.
So the short answer is yes, in public and outside of healthcare settings, masks or buffs, anything over your face is useful. But I think the key point is not to let it be a false sense of security.
Exactly.
Like, I think there's people who have, whether it's a buff or a mask, and they'll just walk right by people as if they don't have to distance too. So it's important that you still do that. Don't touch your face, wash your hands a lot, distance, but yeah, use the mask or the buff.
Social distancing, reducing especially now in the next few weeks, you know, reducing, you know, as much as you have to interacting with people outside the household. The mask is sort of, you know, it's going to be one more level of protection. Hopefully that'll keep us in. So, next question. Hydroxychloroquine. I'll go straight to something not controversial. So you know, there's a lot. You hear this word a lot, especially at press briefings, of this, you know, somewhat obscure drug that's, you know, used primarily for malaria and different types of rheumatologic conditions. But it is part of several protocols for the treatment of critically, you know, severely ill people who have SARSCOV2 or, you know, or in the later stages, more severe stages of COVID19. And you see different combinations with AZT or zinc. What's your thoughts on it? Have you reviewed the evidence? It's actually doesn't take that long, to be quite honest. It's like there's one randomized control trial, one open label trial, and then there's a whole bunch of studies that are open right now. That's pretty much all that's been published on it.
So my feeling on this is I don't think we know the answer yet. You know, it looks optimistic. Am I 100%? But we've had so many other medications over the past few years that have a lot of promise, and then you do a couple randomized controlled trials and you find that it doesn't have benefit. I've seen a lot of different protocols using it with azithromycin, using it with zinc. I know there's a big study that they're doing in healthcare workers about them taking it prophylactically to try to prevent this. You know, I think if someone's in the hospital and they're getting sick, that's a different conversation. For me, in a primary care setting, you know, 80% of the people who get this are going to be able to ride this out at home, not need oxygen, not go to the hospital. So, you know, it's really, you're talking about a small subset that needs something in addition to their own immune system. You know, I worry a little bit. I mean, the med does have an immunosuppressant effect. That's why we use it for rheumatologic conditions. You know, and I worry a little bit if you have someone who's got fairly mild disease and you give them this med, could you be decreasing their immune system enough that it causes their disease to get worse? So I'm still in the wait and see boat right now.
Yeah, I mean, I think that the adverse effects, you know, both in immunosuppression and also severe arrhythmias, there's not something to be really mindful of. There, you know, this is, you know, why you have to be careful even if you're giving it as a prophylaxis for someone going to, you know, an area where it's still, or malaria is susceptible. If you look at the study that a lot of people reference on preventing, or not necessarily preventing it, but preventing the progression to severe illness, I think that's people being very interested in this drug particularly. You know, they often tout, well, if you look at the treatment arm, none of them developed severe illness. However, 2 of those people dropped out because they developed severe medical complications to the drug. So you actually look at the effectiveness of the trial is almost a wash with that trial. The French trial is an open label trial. We have no idea what other care these patients are getting. And there was a really interesting statistical article that did a lot of Bayesian analysis of it. And you just do a couple of these little small tweaks in these variabilities, and then the trial itself looks like worthless. So we really have to, you know, as hard as it is in the middle of a pandemic, because we're panicked, we want something to help very sick people and maybe, you know, reduce the spread of this. I think we have to realize that we have to wait and see what happens. I mean, there was, you know, in the first 3 or 4 months, there's a lot of hope about Kaletra, and as soon as a few randomized controlled trials came out, University of Washington's like, don't recommend this at all. So I think, you know, I think there's about 70 drugs that have outgoing clinical trials going on. I think a lot of people ask, you know, I see a lot of this on Facebook and social media, you know, people wondering, well, should primary care doctors be giving this to at-risk people who are in a high prevalence areas, or if it looks like it's the infection starting to explode? And I would say no. I don't think there's good evidence for that. And plus, you don't want to, you know, inadvertently reduce these medications that are very effective for people with rheumatologic. That could be life-threatening as well for really, really untested drug. All right. Any other thoughts?
Amen, John. I think you said everything. I mean, we could talk about this for a long time, but.
Yeah. All right. So, okay. So this one came from Florida. What's the significance of finding SARS-CoV2 in stool? And can it be spread fecal-orally?
Yeah, I'm an expert in this. Just kidding. Yeah, I just read there was some paper, but in the gastroenterology literature. Anyways, we're not. It could. I don't think this is that well studied, Andy. I know that there's, you know, to put this in context, I mean, they have a lot of cases that either as the only or an initial symptom, people get gastrointestinal symptoms and diarrhea, for instance. That does not, at least in our medical center with the testing that's available now, trigger a COVID test in the absence of respiratory or other symptoms in most patients. But what's the significance? Yeah, we'll know this maybe months from now, the full significance. Andy?
Yeah, I mean, I read today that they're finding it more in cats. You know, I mean, just the whole shedding thing. I mean, every time we learn something, you know, the tiger at the zoo in Bronx got it the other day or something. So, yeah, I mean, just the shedding and the passing on. I agree with you. We just do not have a good handle of what's actually going to be significant.
Sorry.
Go ahead, Mark.
Just one quick point. There's a lot of illnesses that are passed through the stool. And in general, I think we all know when you deal with stool at all, like you should wash your hands really thoroughly. So just as a way that this would impact someone, let's say you got some gastroenteritis from rotavirus or some other gastrointestinal symptom, and you got so dehydrated and sick that you had to go to the emergency department for IV hydration and treatment, therefore exposing yourself to an additional risk of contracting the COVID virus. Get what I'm saying? So anyways, it's the same stuff. This hasn't been worked out. I don't know if answering it is that high of a priority right now.
I think it'll probably be a much bigger factor in developing countries, and it may have a factor.
Yes. With less poor hygiene or not access to clean drinking water or even any running water whatsoever, that's been discussed. It's going to be a big problem.
All right. Last kind of general medical question, kind of a topical question, I guess more of an analysis of the media ways. But so my question about Boris Johnson, like why was he put in the unit but not a ventilator? And you know, why would somebody be put into the care unit but not necessarily a ventilator? I mean, to me, I explain it, but quick answer to that.
Aside from COVID-19 infection, any patient generally no one's going to go to an intensive care unit without passing through an emergency department. So whenever I see a patient with any medical problem, you know, the big thing that I'm trained to do is trying to recognize, is this patient sick or not sick? Sick meaning generally you'll have to do some intervention and or maybe admit to the hospital. And then among those that need to be admitted, are they really sick that they have to go to an intensive care unit? So every condition or every complaint, there's different criteria and things that you look at. And it's not always a simple algorithm where it's that obvious. So in my case, for instance, I don't actually admit anyone to the hospital. I evaluate, I treat, and then once I figure out this patient is not going to be being discharged home, they need to be admitted, I consult an inpatient consulting service. So it's either the hospital-based services for patients in the floor, or they go to an intensive care unit under the care of an intensivist, although it's a little complicated because off hours, the hospital-based specialty physician actually will admit to the unit because the intensivist is not there at all hours. So hopefully that wasn't too convoluted a question. So we could go into criteria of why someone would go into the ICU versus the regular floor for COVID. But it's pretty technical, and I think it probably varies by institution, their capacity at the time. For instance, in New York hospitals, there's patients who need to go to the intensive care unit, and they're not even going to be, they're boarding in the emergency department, probably on the floor somewhere. That's from what I understand, that happens. So it's not a simple question. Did I answer the question enough?
Yeah.
I think so. Andy, do you have anything to add? It kind of sums it up, I think.
I think Mark did a good job with that one. He has more experience in that realm, so I'm going to defer to him on that one.
You're not intubating in your clinic, Andy? Come on, what is that? Are you a doctor? Anyways.
So
that's why I married an anesthesiologist.
That's right, that's true.
In terms of about Boris Johnson, I'm very probably there's lots of good reasons he's in the intensive care unit, and amongst them is he's the prime minister, and they want to have as close a watch of him as possible. All right, so that was our general medical questions, but now these are a series of questions that are more focused on trail running and ultra running, and then if we get a small chance, Andy, just I don't know if you want to say anything about the Western States decision about holding it. So people might be interested in that as your medical director. So there's a number of questions about if you're running on a trail and you run and you're running by somebody, what's your exposure risk? And so one had a specific scenario, like, and Gary Gellin asked me a very similar question earlier as well. It's like, so if you're passing somebody or you're running past somebody and they just happen to cough at that time, can you catch coronavirus?
And given the gastrointestinal question, like if someone farts, like not, right? These are good.
Well, coughing, yeah. Theoretically, that could happen. You're running by somebody, and then all of a sudden they have like a coughing fit, like right as you're running, with feet of them. So.
Yeah, so I don't, this is one I'm getting a lot of. I have a couple good friend who's a writer. He's been writing a lot about this. There was just an article that came out on medium.com today where they did some sort of graphic modeling looking at running and biking and walking. And they actually recommend with cycling being almost 60 feet apart. That they also sort of did some modeling where, like, if you're passing by people, it's not as bad. If you're side by side, it's not as bad. It's more if you're cycling and you're in someone's slipstream, that's, but it was a weird mathematical model. They didn't, they can't really take into account crosswinds, headwinds, tailwinds, whatever. So, I think people just need to be smart, and usually what I'm trying to do on the trails is give people more than 6 feet. There's usually plenty of space, give them 10, 12 feet. But again, I think this is one of these ones where we just, the data on how rapidly this can spread in the air is just, we don't know yet.
Yeah.
I don't know if we're ever going to know because the latency period of this virus is so long.
Right.
There's so many exposures. It's hard. It's a very interesting question. I think about it even just like if you got your car and you got your window down a little bit and you're driving around, right? Yeah, I mean, it's conceivable, right?
Right. And I think there's other variables. I mean, I have not seen a lot of data. I mean, people talk about heat. This virus doesn't like heat. So if you're out and it's 60 degrees versus 80 degrees versus 95 degrees, I haven't seen any data. I keep wondering about humidity. New York, the humidity is pretty high there. Does the virus not do as well in dry climates? I'm kind of hoping for that living in Reno. But, I think there's just a lot of questions with it. Aww.
Yeah, I know. I think some people might have been glazed over on that one, so I just put my dog.
Yeah.
Just kidding.
There's, the seasonality, we just don't know. I mean, if you look at sub-Saharan Africa and Equator, it looks like it's doing pretty fine in terms of spread. So I think a lot of what they talk about, the season, thinking there will be a seasonality is based on experience with previous coronaviruses. But I hope so. I think if we're going to see a break, it'll probably be mostly through mitigation efforts and also just running its course in the outbreak.
Right. That's with regular flu. With flu, they say that some of it is a temperature. Oh, sorry.
No. I was just saying to go back to the person's question. I think it's a significant risk. We just don't know. I mean, I think if that's the problem with a virus that has such a long latency period, you may feel perfectly fine and be out there running and doing very hard efforts and spreading this virus, and you don't become sick until a week, 7 days or even 14 days into your initial infection and you're shedding a lot of virus. This really goes to the point of, staying at home, staying close to where you are, and going out as little as possible. Yeah, go ahead.
No, I was going to say, bicycling.com actually had a really nice article about this too, and they quote a friend of mine, Brian Labus, who's sort of our head infectious disease epidemiologist for Nevada, really, really bright guy. So that's another good resource that I've been pointing people towards, is the bicycling.com article.
Yeah. Yeah, I think that's a good thing. So, I mean, there's another question in there that kind of maybe goes, about fomites, but like, if you go running on a trail and there's a lot of hikers, a lot of people out there, can you bring this virus on your shoes back into your house? Should there any special protocol you should do, if you, after running with your clothes and shoes?
Again, there's no study. I was thinking about this, and I also think about this because after my shifts, we don't have laundry service for our scrubs or what we wear to work. So I've got to bring all these clothes and my shoes back home after I have work shifts. And there's a lot of discussion. I mean, I think one of the Kaiser Permanentes up in Walnut Creek they came out with this long procedure, and you can get other things online about what to do, like have a hot zone, a location where you do this stuff and use your garage, etc. I don't want to go into it too much. Thinking about someone who spits on the trail and someone steps on it, I'm guessing that, after stepping on it and you're stepping on thousands more pieces of dirt, probably there's not going to be too much that's going to be sitting there. But yeah, obviously, people, you really shouldn't be wearing your trail running shoes into the house anyways. I'm Asian, so we don't wear shoes into our house in general. I yell at my kids for doing that, but the general policy is that we keep most of our shoes outside anyways. So consider it dirty regardless.
If you live in an urban area and you're a healthcare provider, it's maybe different than if you live in a rural area. Andy, what's your thought?
Yeah, I mean, typically what we've been doing is we know this virus does not like soap and water. That's like one of the few things that I think that there is kind of agreement that soap and water together this virus does not like that. So, what we've just been really trying to do is, I'm not washing my shoes all the time, but, when we get home for a run, we throw the stuff in the wash and we take a shower. When my wife and I go to work, we come home, it's not like a hot zone, but we come home, first thing we do is we jump in the shower and scrub down. So I think some of those really simple things of, you might get, I think that's another thing that we don't know about this virus is if you get exposed to the virus, is that virus going to be within you within milliseconds? Or is it the kind of thing where it hits you, you rub your face, and if you just wash your hands enough, wash your body enough, that even though you might get exposed to that virus, it's not going to really start causing an infection.
Yeah, I think, it's a repetitive exposure. I think that's why you see such clustering in amongst work people, healthcare providers, and at home. I'm trying to be mindful of your time here. So shelter in place orders. So this is a question I've heard from a few people, and there may or may not be a right answer to this. So let's say you live in an area that has a shelter in place order or quarantine or the equivalent in other parts of the world, where basically you're supposed to stay in your home. You can go out and do some exercise, but the idea, you really should only be driving places or going places for, either emergency or for, getting food, things that are, you have to do this to stay functioning. So there are people who are concerned about people driving to a trailhead, driving to, like we live here in Sacramento, it's very flat. So, And for us, we've been living here for a long time, it kind of feels like, oh, we're going to our backyard to drive up to Auburn. But in reality, it is, it's a 30 to 60-minute drive to get to a place. And, is that really, are we really, by doing that, are we following, what the social distancing and mitigation should be?
So this came up in some social media posts. I don't do that much social media, more recently maybe, where for instance, one runner posted pictures of a ice, run up all around Mount Diablo, and then there were some comments about, shouldn't you be staying at home? He drove not into the park, because I think already at that point you couldn't park inside the parks, maybe early on, but even now you can't drive into the parks now. So, and I made a comment that when you're in your car, you're not really a risk to anyone, and running all for how many hours you want on a vast, uncrowded, state park on trails is really not hurting anyone. Where this comes in play was that I think that first weekend, and we're in Southern California, everyone flocked or all over the state, people flocked to the beaches and these parks, and it was very crowded. So, and you could run near your house, and if it's a kind of crowded area, that's not any better, even though you're staying close to your house, if the density of the population is a lot. So I think, the idea is people don't be going out and congregating, but and I think there's a lot of variability with, how crowded trailheads are, single track versus fire roads, wider trail, wide trails, how busy the park is, the hours, etc. So I personally think that if you can run and you can avoid people and you're doing everything else possible to mitigate, that's responsible. And I think if it's good for your health, it's good for you. And this is a tough time for a lot of people, aside from trail runners. It's people they don't have jobs, they're stressed out. It's tough. So whatever, if it doesn't really increase the risk of contagion and infection, I think it's a good thing. Just, you gotta think about it logically. Yeah, go ahead.
Well, no, as I was saying, so from that point of view, like if I hopped in my car and I drove to Andy's and Truckee and just parked there and went running on the trail and drove back, that would be okay.
I think so.
So here's the thing. I think this is where I think
if the roads were, well, oh, sorry, go ahead.
Well, no, because here's the thing. There are a lot of stuff that our perception of risk is oftentimes highly biased, and we're not very good at understanding risk. I think epidemiologists really look at movement. If you really want to stop a novel infection in a population that has a high infectivity, you want to reduce movement in any way. And so it's not, so even though you feel that you're moderating personal risk, you may inadvertently you may be asymptomatic and never even have a symptom, and then you're bringing the infection to an area where you wouldn't. So that's the argument against that. I think I'll talk about what I do in a second. I want to go what Andy says first.
So, look, I've been going back and forth on this one. I think another really interesting issue is we're seeing, and we're seeing this all over the country, are the people who have second home. They're living in a major metropolitan area and they have a second home in a more rural area, and there's obviously getting to be a lot of debate about that. I think right now if you need to stay in your location. I do, from a comprehensive nationwide perspective, I was almost like, man, if everyone could disperse around the country, that actually, if everybody in New York could have dispersed out of New York, or half the population, that probably would have helped them right now. Assuming they were disease-free when they left. If in early March, I was reading something the other day, or I was listening to a podcast the other day, and one of the guys was talking with an epidemiologist, and they really felt like, you know, distance is the key with this. People just need to stay separated. So I kind of go back and forth. You know, I struggle with this personally. Like, you know, where we're at, we're fairly dispersed. You know, it's fairly wide dispersion. What's the harm if I go to another place that's equally dispersed and I'm not interacting with anybody during that time? You know, I think the other thing that I'm also trying to take into account is, you know, the odds are low, but what if I get into a car accident? What if, I mean, all these like little things, you know, if the roads are, I mean, you know, we're talking about maybe going up to Truckee. Well, if the roads are bad and it's snowing, I'd be a real idiot if I got up there and I got into a car accident because my car slid out in the snow. So, you know, I don't know. I'll admit, I don't think I have a good answer. I mean, I think the biggest issue is just making sure you're away from people. I think ultimately, if you're doing that, I think we're going to be okay. But I'm not 100. You know, but yeah,
I think movement is a key factor. You want to limit the distance that you travel, because that, if everyone does that, it does have an effect. I mean, realize
again, just to
less than a month, this virus was in, you know, it was a handful of cases in the coast, and then it's every less than a month. It spreads very, very quickly, and it spreads silently.
Right, John. So the distinction though is like, I mean, is it okay if I don't want to run around my house for me to drive 20 minutes to another park, right?
Yeah.
That's the typical question I think that's coming up, right? That's one thing, as opposed to, I'm going to go and travel 2 hours to Truckee and I'm going to stay someone up there and I'm going to be shopping there. You know? I'm going to be setting up, or, you know, even if you make this a day trip, what else are you doing? Okay.
Yeah.
I mean, I think, again, and the whole concept of stay at home, I think part of it is people are going to push it and they're going to extend past what the spirit of it is. And so you've got to kind of lay the law down, and I'm all for that. And I appreciate all those efforts, but I think individually, the idea that you can't go anywhere it really is the concept. So just to give, when I have run in the past, okay, you know, I don't even open the gates with my hands, all right? I actually sit there, either get like a leaf or a stick to undo the latch, and I'm opening it with my foot, okay? Because even if I'm being clean, I don't know, there's people out there hiking or running or whatever, and maybe they live right there. Maybe they're local because they can walk from their house there. But if they're not doing that, right? If they're not doing the same thing and being that careful, right? So, so all I'm saying is that I think the travel in and of itself, out of the context of everything else, it doesn't seem like an absolute to me. And I think people have to think you can be transmitting a heck of a lot just by not, I don't know, even if you're staying local. So I think people need to be thinking about what they're doing at all times and adhering to these general guidelines. But so sorry I went off on that and was a little scattered.
Andy, did you want to say something?
Yeah, I think Mark brings up another good point. I mean, I guess I'd rather see people go out to a trailhead where there's, you know, if they have to drive 20 or 30 minutes to a trailhead where there's nobody, then go to a trailhead where there's 30 or 40 other people there, you know? Yeah. So, I mean, I think there's just so many variables that go along. You know, to me, the biggest thing is we have to stay distant from each other physically.
Yeah. So my view on this is, I think the reason there's controversy on this is because there's ambiguity in the rules. And ultimately, you know, a state, a government, and health system has to make decisions on a pandemic that the population is not going to like. Stay in shelter is a sacrifice. And it's a sacrifice in many different areas of it. And ultimately, I think, the fact that the trails are open and people who live there, like Mark is a very good point. Like if you're lucky enough to live near one of these areas and you can walk and get to the trailhead, that's fine, but you could still be, spreading it to other people on the trailhead. Ultimately, I think it's, that's why, we didn't have a very good plan for dealing with this. And ultimately, it needs to come from the top down. There needs to be very, this has to be defined, or it ends up causing more derision because people are interpreting the rules in different ways. For some people, from somebody looking at from a purely epidemiological way, like somebody's like, we want to stop this deadly disease. The idea that someone's choice to drive 20 minutes, even though they have all of these, we've intellectualized this, and we've come up with all these reasons why we should do it. It does still may not make sense to them. Ultimately, we have guidance from the top to say like, what are the rules in order for us to, have access to the trails. Now, some countries, are locking down on this. In England, if they see you out there hiking, they're like taking drones out there, and then you get fined or they'll shame you on public media. I'm not saying we should do any of that. And I don't think what Andy's saying, I don't think there's a good answer to. I think we all have to make that judgment right now because there isn't for now a firm rule. Now let's say if things look like New York here, I guarantee you they'd probably shut down all if we had cases like this. If the death rate was as high. But ultimately, I think California, even though we look like we're better to the rest of the United States compared to other developed countries, not that much better. And so, I personally really take these shelter-in-place rules very, very seriously, not just for protection of our own family, but for that as a healthcare provider to be a role model to like how we want people to act. So that's just my point of view on it. So, let's move on to something less controversial. I think we're close to the end. In fact, we are. So we did have a writing question about produce. So are vegetables safe? This is from Instagram, I believe. So are you doing anything special with produce or vegetables?
I'm eating them. Again, we're not seeing much with fecal oral. Would it hurt to wash them down? Again, we know soap and water works. So if you're really concerned, wash them down. And, and hot water probably maybe works a little bit better. I think if you're going to cook your vegetables, it's not going to be an issue. Raw vegetables, you might want to take a little extra time and wash them.
Yeah.
I mean, probably if you had packaged salad and you didn't get to it for 2 or 3 days, you're probably okay. As I don't have it in my household, and it's complicated because I'm a frontline healthcare worker, right? We don't have set in stone rules. And to give some context, my healthy but 85-year-old father lives with us. I have my wife and I have 2 kids, a preteen and a teenager. So, as my wife was saying, she has friends who have a meal protocol where they don't touch it for 3 days, and she's got other friends who do this complex produce, not even produce, but the packaged food, disinfecting procedure after shopping. And as this is not sustainable, right? You can't. How long are you going to be doing this for? Really, it's until there's effective vaccine so if people want to do that, I guess that's okay if you can sustain it. But we open our mail and we wash our hands, but there's a lot of. I think I don't want to criticize that kind of overreaction. I think it's much better than the people who are just not buying it, that there's even a problem, and you'll still see this. I mean, there's people out there who don't distance at all, and you can tell. I saw from my car some guy at a shopping venue who was touching his face a million times, didn't have a mask, and did not seem fazed by any of what was going on around him, as an example. So I think it's better to be safer, but yeah, we're not worried too much about, wash your produce, but I don't think we're worried about catching it there. Again, my situation is different because I'm a frontline healthcare worker. So yeah. I am a problem in and of myself. So.
Yeah. Andy, you doing anything special with your lettuce?
With what?
With your lettuce?
No, no, I mean, again, I think it's just normal, good hygiene things. But yeah, we're not doing anything particular special in terms of wiping down I mean, again, both my wife and I are healthcare workers, and we're like Mark, our biggest risk is, just bringing this back from work, from patients. So.
Yeah. Yeah.
By the way, sorry. I heard that, someone was explaining to me, which I kind of knew, but, there's no such thing as a baby carrot, but I guess those baby carrots that come in a package, I guess they get bleached. Like there's some bleach treatment they do to them. Is that true? Yeah. Anyways.
They're cut down to the shape too. Yeah.
Yeah.
I think there's probably more risk from just walking around people in the grocery store than actual produce, but.
Right.
So.
Yes.
So anyways, we're going to start wrapping this down. We're going to land this plane, and to quote Rich Roll, but the one thing, I just want to kind of do a kind of summary, about this whole drive to the trail thing. As our audience can see, there's 3 healthcare providers. We all are very professional. We all have highly ethical, do a lot of work for people, and we all have slightly different opinions on that. And I think ultimately you just got to follow the law. And as long as you're following the law to get to your trailhead, then it's your personal decision. So.
Are you going to let Dr. Pasternak talk about Western states and all that?
Yes.
You mentioned that. I want to hear that. That's interesting.
Can you tell us the behind the scenes on?
Yeah. So this was going to be my first year as medical director of Western States. Picked a great year to do it. And so the Western States Board and the President Diana Fitzpatrick and Craig Thornley, the race director, really probably about 6-8 weeks ago when this started to hit. Really in early March, they're like, is this going to happen? And Craig and I had a lot of conversations, and Diana and I had some conversations, and really I got to give credit to the Western States Board. I mean, I sort of gave them my thoughts of when this was going to peak. At the time, early March, we were talking about some of this. We were really talking about the peak hitting right about now, and then it would, we were going to see this huge peak, and then we'd see a drop off. But as the social distancing stuff occurred, and some of the projections for overall deaths were occurring, and the other consideration is, Western States is such an international event. Runners from all over the world, everybody's really on lockdown. That I think the board really kind of took a step back and said, this is really, I don't want to say cruel, but asking runners to train for a 100-mile race right now. And, in April and May, they really need to be ramping up and doing 30, 40, 50, 60-mile runs. We really can't be asking our runners to do that. The runners should be sheltering in place. Yeah, we want people to stay active, but to do those really long runs, during this time where people are really sheltering in place all over the world, just seemed really irresponsible. So I think they appropriately, and I heard the same thing with a lot of the Olympic stuff. With the Olympics, it was some of the swimmers were like, we can't train right now. Katie Ledecky was training in a backyard, a 20-yard backyard pool, just trying to keep her strokes up. And so, are some of these restrictions going to be gone by the weekend of Western states? It's possible. You know, but I think the board really made a really good decision of, hey, this is not the time that we want people to go out and be training. You know, stay at home, stay in place, and let's worry about the race next year.
Yeah, no, I think that was. I think you probably contributed to saving some lives and really helping control this pandemic. That decision, given the number of people who come to the race.
Yeah, I think that was a good call, and it's interesting because I'm signed up for, let's see, signed up for San Diego 100 at the beginning of June, Hard Rock in July, and Wasatch at the beginning of September are the races that I'm enrolled in. But you know, I'm just thinking, even if these peaks, you know, or California, wherever the host place is peaks, you don't know what the peaks of people that they're all, you know, these aren't. Hard Rock is fairly international too, I guess, but you know, people are coming in from all over, and even if a place has seen their peak and coming down, like, you know, people are coming from places where it might not be that much on the downhill, and then you've got, you know, just because the slope is going down doesn't mean that you can reignite it. I mean, that's what they're seeing in like China and South Korea and Asia. It's like, now we got to put out these little embers that are lit up. So I'm actually, I think at least those first two are gonna get canceled. San Diego, I'm like, look, Western States is several weeks later. You guys should just call it.
Yeah.
But good move. Yeah, I was good decision, Andy, and I think you acted early, which is good. I think it set an example for a lot of other.
I think it set a really good precedent and really good role model for really what a lot of other races should think of how to act. So gonna wrap up here. I just want to hear like your number one or suggestion for dealing with shelter. What's an advice for dealing with the stress of? Sounds like, Mark, you have like the whole spectrum of family in your home. So how are you dealing with that? Like, you advice? You
wanted a one word?
No, one idea.
This is really hard because it's hard for me to say anything. I honestly, I get a lot of, you know, thanks for being a frontline person, being out there. You know, I'm just really grateful. I have job security, and even if I get sick, I have job security. I have a job, and I think this is just, it's really hard on so many people. I mean, it's probably beyond what I can imagine. So, you know, if you're making it by, if it's difficult, I think one key thing is just gratitude for wherever you're at. Again, I'm not going to preach to someone who's got it really, really tough, but if you're watching this, you're probably in good enough position that there's a lot to be grateful for. It could be a lot worse.
Andy?
Yeah, so kind of like Mark, I have my 79-year-old mother-in-law living with us, and you know, this is a woman who grew up in Italy. Remember, you know, she, as a young child, she remembers Nazis executing someone in her town square, and then post-war, where she was in post-war Italy, there was not a lot of food, and you know, this is obviously tough. People are taking a financial hit. It's really, you know, this is pointing out a lot of the inequities, I think, in our healthcare system. Fauci gave a great talk today about what this is really showing us in our African American population. There's a lot of people that are getting hit by this really, really hard. But you know, I'm really hoping, I think we all are, that within, you know, that this is going to turn around. This is going to get better. We're just trying to stay optimistic. Again, I'm sort of looking at this like an ultra marathon, and in some ways, you know, I sort of feel like, okay, at least to me, the first couple weeks were the hardest. Now I sort of feel like, okay, we know what we're dealing with in the medical community. I think we're not scrambling as much. We're still scrambling. We still need tests. A lot more tests. You know, the PPE is getting better, but we still need more. But, you know, I sort of feel like at least we're getting some things in place, and it is good to see that this curve is flattening and this is paying off. You know, but we're still going to have some bumps down the road, and it's going to be tough.
Totally. I think that's a great analogy. Well, I really appreciate you taking the time to answer our questions and talk about this important topic.
And I'm practicing my tuba. Sorry.
Awesome.
That's a good. Yeah, I think it's important to try and do something creative every day and do our best to stay positive. But I really appreciate both of you lending your expertise, and I think I was scrolling through it, but we got a tremendous amount of positive feedback on the Instagram Live part of it. So what I'm going to do is we'll save this Zoom call, and then I'll upload it to Instagram, so it'll be a more permanent place there, and then I'll upload it to YouTube, and I'll send you all the links and stuff like that. But you guys are great. It was
cool.
Thank you again.
Thanks, John.
Thanks, both of you.
Good
Thanks,
seeing you, Mark.
Andy. Thanks, John. It's great
All
seeing
right.
you guys.
Yeah.
I'll see you live in person someday. Hopefully
I
not
know.
too long.
Yes. All right. Bye.
All right. Bye-bye.